Minnesota, and he has spent most of his career as a chiropractic physician studying scoliosis and understanding the biomechanics of how the spine twists and turns and why we have lordotic curves and kyphotic curves. And I'll be honest with you, to me it's very complicated. It's an art and a science, and it's like mathematical, but he makes it easy. And he's had his DMX for how many years? 9 years. And now he said he'll go into how he's used it to see if the treatment works or if it doesn't work. And it's okay, that's part of learning. You know, you want to check your work, and either the patients can get better or not. And he has patients that fly in from all around the country and the world. They spend literally weeks at his facility. He actually built out a condo or two in his big building where people can stay with the family while they get treated 3 times a day. He'll get into that. So it's an intense treatment, but when you're changing, it's like moving teeth for a dentist to put braces on. He's doing that to the spine in a relatively quick time. And he does from little kids to older people, all ages, which they say that's impossible. So I'd like to give a great welcome to Dr. Dennis.
Good morning. I graduated from Palmer in 1974, and at that time they didn't teach us anything about scoliosis. Except Palmer's philosophy was you don't adjust the spine for symptoms, you adjust it for subluxations. Except in scoliosis, because chiropractic can't help scoliosis unless they have neck pain, headaches, or back pain, then it's good for that. See the philosophical whiplash? Didn't make any sense at all. My disclaimer is I just want to have fun. I have attention deficit disorder, and I'm also hyperactive. So it's a good combination. You see, this is what we're going to be doing tomorrow. In 1992, I got certified in video fluoroscopy by volunteers through Palmer College of Chiropractic. I've known John and Linda for about 16 years, and I've seen them at the Parker seminars. And it's like, okay, John, can you give me like a DMX of a scoliosis patient? So I called him probably once a week for 2.5 years trying to get this. He had to go up to the attic and finally find it. I figured it would probably be more time efficient if I just bought my own DMX machine. Right? So when I was a kid, my parents bought a resort in northern Wisconsin. We had 9 cabins and a lodge, and ran it for a while as a resort. And it's a lot of work, so they formed a corporation and sold the cabins primarily to Methodist ministers and chiropractors. One chiropractor who graduated from Palmer in 1916. So I got to spend a lot of time with him, just sitting around. And we were down at the seminar in Panama, 10.5 years ago. And with the cabin, the American cabin site, pretty much what happened, we'd go up in the springtime, clean up the whole cabin, get it ready. Everybody else in the world would use it in the summertime. And then we went at the very end of the year and cleaned up everything, fixed all the broken stuff. So we're at the seminar, and Brenda's there, and we're listening to Dr. John speak, and I love DMX. I dream in X-ray lengthness. And Brenda says, we got to get one of those DMX machines. I said, what are we going to do? She goes, we're going to sell the cabinet. I said, cool. So we sold the cabinet. I used the DMX machine to have more fun with it than I ever did with the cabinet. Honestly, about a year ago, it broke down for 4 days. We got it fixed right away. I would not practice if I didn't have my DMX machine. I go through withdrawals, a DMX withdrawals. What I'm about to tell you is going to change your life forever. Are you really sure you want to know it? This is an email I got. I just saw your website, was amazed. I was born with scoliosis, that's with my sister. We both suffered terribly all of our life. I am 59 years old now. I had my first of 6 surgeries at age 21. I wore the cast for 3 months and the brace for almost a year, and the pain from surgery was excruciating. Now that I've had 6 surgeries, the breakdown of my spine has reached my neck. Right now I'm facing yet another surgery to fix ongoing problems, severe problems, osteophyseal stenosis, etc. Scoliosis is hereditary and supposed to skip a generation or so, I've been told. My son now has it and thinks that surgery is the only answer. I told him that he would have surgery over my dead, lifeless body after the life of hell I had to go through. Thank you for your advanced this with the 5 months alternative. So this is what we're seeing. St. Francis says, start by doing what is necessary, then what is possible, so we're doing the impossible. So here's Eddie. This is back in March. Eddie came in, spent 2 weeks with us, 41 degrees down to 21 degrees, 32 degrees down to 20 degrees. Scoliosis cannot be cured, but it can be controlled. Like diabetes can't be cured, it can be controlled. Blood pressure can't be, high blood pressure can't be cured, it can be controlled. So our goal is to control it. We do lateral flexion to see where the hypomobility is in the spine, as well as the hypermobility. And I use the DMX on this to lateral flexion, take a picture, print it out. We do a lot of spinal weighting. Instead of bracing, we're going to get the joints to go into a new position, have the brain memorize it. So I do a DMX on it, and then I'll take an X-ray so I can see exactly what the spinal weighting does. Took from 41 down to 26, 32 down to 23. Upper cervical subluxations are very important. Now, he's got a 41-degree left cervical thoracic cob angle here. So he basically has a left high shoulder. So post X-ray came out 3 down to 0, 4 down to 0, and that cervical thoracic cob angle from 41 down to 21 degrees. You've got to look at the entire spine. Doctors ask, do you do like heel lifts on your scoliosis patients? No. If you correct the upper cervical subluxation, 95% of these people that don't have an anatomical shortcut will balance out without doing heel lifts. So the idea is if you get that cervical spine corrected, you don't need to do any type of a heel lift or a shoe lift. It's very important, as you can see, to be able to restore the normal cervical lordosis. So he went from a 297% loss of curve with an 8-pound good weight and a 10-pound anterior chest weight to a 0% loss of curve. I'll just show you that. Okay? This is a teaser. We do posture pictures. You can see how the rib arch sticks out here, and after 10 days, see how flat it was. Cosmetics is a very big thing. As a matter of fact, the major reason for scoliosis surgery is purely for cosmetics, and it doesn't work. We do pictures with the spinal weighting. Something new I'm going to show you, there's a scoliosis part. It's a new exercise that I just came up with. Now he's got his head turned to the right side because he's got a left high shoulder. So we're going to balance this out by working the muscles. We utilize a scoliosis traction chair that I designed a few years ago, which becomes very important. Now this is Jane, she was 9 years old, so juvenile scoliosis, not adolescent, juvenile is under 10. But 25 to 23, 4 to 12, 7 to 12, 14 to 23, she got worse there, 15, 26, 10, 18. Parents said, well, what else can we do? So what I did is we put her in the scoliosis chair, took her down to 3 degrees and 2 degrees, and now she's doing the scoliosis chair at home. I'm going to show you, I have to DMX the patient in the scoliosis chair to make sure I get the placement correct. Spinal weighting, this stuff is pretty amazing. Gray's Anatomy says human beings adapt in time and need to their environment. So guess what I'm going to do? I'm going to change their environment. Here she's doing the scoliosis bar. This is Macy, 27 to 9, 18 down to 8 degrees in 4 days. Here's the scoliosis X-ray in the chair. Spinal weighting that we did. We DMX it, then we take an X-ray. And again, she had a 10 degree cervical thoracic cup angle down to 3, upper angle 2, lower angle 2 to normal, over normal, and her legs balanced after that. 68% loss of curve, which an 18% loss of curve with a 3-pound hood weight and 5-pound anterior chest weight. We're going to look at that too, doing the spinal weighting, scoliosis bar. It's fun working with these kids. I have such a good time. I'm basically, Brenda says I'm 10 years old with 55 years worth of experience. So I get along with them really well. Rhonda, severe upper curve, 24 degrees, a lot of pain. Got her down. This is in the scoliosis chair. Beat correction chair, 25 down to 13 degrees. You know, you always hear people say, I've got a cob angle of 55 degrees. What are the other two cob angles? If I had a 55-degree cob angle, I'd be walking like this. The body has to compensate to gravity. So there's going to be a lumbar cob angle, but there's also a cervical thoracic cob angle. It has to be there. And we've got to look at that whole thing. 144% loss of curve to 79 with 10-pound hood weight, 10-pound anterior chest weight. Into SLA again, doing spinal weighting. This is Dr. J. He's a chiropractor in Florida, and he's having some severe back pain. They had to do surgery to fuse his lower back. They didn't want to touch the scoliosis. He couldn't do anything. He couldn't walk. He practiced maybe an hour a day, and that was it. And they came up to see me, 48 to 42, 31 to 22. Got the cervical spine corrected. He had a severe lordotic kyphotic S-curve. That started to come back. We look at the rotation of face posterior X-ray. Look at him cosmetically. He came back in June. We don't call this a rib hump. Hump is a bad 4-letter word in my clinic. because it's kind of a psychological thing. You know, the little girl, look at the little girl with a humpback and lower down. So we call it an arch, like a rib arch, or a golden arch, or a Roman arch. So that's an arch there, it's not a hump. We do, actually I use the Wii Fit to do measurements for balancing. And that gives me 90 degrees, spinal weighting. He's got to see everything change. Got a little boy that came in for 2 weeks that I shared with you. He was in such severe back pain, he could hardly walk. By the end of 2 weeks, he was playing basketball for 3 hours at a time. So this came on. I'm always looking for interesting stuff. April 2006, so last month, the effective chiropractic techniques and cob angle and eating is rising in adolescents. Good article. It should be very interesting. Journal of Physical Therapy Science. The purpose was to determine whether chiropractic techniques would reduce the curvature of idiopathic. There were 5 healthy elementary students that were studied. They did 30 minutes, basically massage and manipulation. It's established that the cob angle was noticeably decreased after 4 weeks of intervention. Post-hoc analysis revealed the cob angle would be decreased after 4 weeks compared with the cob before. However, no significant difference in cob angle was evident after the 4th week. It doesn't make sense. Okay? So what I do is and they said the study demonstrates the chiropractic technician can effectively reduce the cob angle within as little as 4 weeks. So chiropractic techniques were effective. So I did the whole paper. I want to find out, is this junk science? Is this junk research? So I started looking at this. And first of all, they stated that the cob angle has to be above 10 degrees, right? That's the definition of scoliosis. Well, they had 5 candidates, 2 of them were 10 degrees. They're not scoliosis patients. 40% of the patients in this report didn't have scoliosis. Then the other one had 13 degrees, 11 degrees, and 12 degrees. So I'm looking at this one before, and as I read through it, they say, reminding the Greening reported that as a result of systemic review, chiropractic techniques, manipulation, positive effects of reduction of cob angle were achieved. Now, I know Stefano Negrini. I'm actually doing a sort online class for like 9 months to learn more about scoliosis. So I went up to his paper, and what it actually says, and this is what they referenced in this their paper, they found 145 texts, only 3 were relevant to our study. Now, one of the 3 satisfied the required criteria because it was a combination of other techniques and other things as well. So their conclusion is the lack of any serious scientific data does not allow us to draw any conclusion the efficacy of manual therapy is an efficacious technique of treating adult scoliosis. So they used a reference that negated their paper. How stupid is that?
Yeah, that's terrible.
Yeah.
Well, the paper was junk to begin with.
Yeah, it was.
There's no evidence that manipulation can change curves whatsoever.
No, not there. There isn't. Now, this is chiropractors published new research in the Scoliosis Journal. My son Josh works with me, Dr. Josh. Recently, we did a data safety collection study on over 3,198 scoliosis visits in our clinic and other clear doctors' clinics. We wanted to find out if this type of treatment was safe as far as these kids go. Parents want to know, yeah, does it work, but they also want to know, does it safe? What are the side effects? 18.9% had some type of muscle soreness, and that was it. There was no disc herniation, there were no strokes. And this was the first time ever that chiropractic was published in the Scoliosis Journal. And this is just like a few months ago. So that's really cool, not doing junk research. This is from the National Board of Chiropractic Practice, 2015. It just released about a week ago. But they started looking at it in regard to scoliosis. 69% of respondents of the chiropractor was the sole healthcare provider for scoliosis. Now they looked at the frequency chiropractors saw patients. For a loss of curve in the cervicolumbar spine, they'd see them daily. 73% of the chiropractors, 83% of the chiropractors treated these patients solely just to get a good cervical lordosis back in the neck. I know chiropractors aren't that good. I've seen their x-rays, okay? When we look at scoliosis and look at functional scoliosis, they're going to see them twice a month. Basically, solely treated 69.9% structural scoliosis, which is the major one concerned about that has to do with the rotation of the vertebrae, your adolescent idiopathic scoliosis. 52% of BC self-managed structural scoliosis. That's not good. We always try to work with the orthopedic doctors at the same time. Now this is real interesting. This is the timeline of the natural course of scoliosis. Right around the age of 10 to the age of 15, it accelerates and gets worse. We see scoliosis more in girls than we do in boys because girls go through their puberty first and growth spurt second. Boys go through their growth spurt first and puberty second. Hormones have a lot to do with this, and I can spend hours talking about hormones. We find that with scoliosis treatment, we get our ups and downs, which is definitely much better. We also do intensive treatment, which works much better as well. If I see a 10-year-old girl with scoliosis, I'm going to be seeing her until she's 18 years old. It's a long-term commitment. It's a long-term relationship. I'm not going to be seeing her 3 times a week. As a matter of fact, there's some kids I check them like maybe twice a year, and that's it. But scoliosis is a progressive disease that accelerates at 11.7 years of age. That's when it starts to get worse. All chiropractors should be doing scoliosis screenings in their clinic on the kids from the age of 10 to 15. And every single one of you should be using a scoliometer. This is what you run down the spine instead of doing an Adams test. You do an Adams test when you run down this on the spine. 7 degrees here is 20 degrees on an x-ray. 4 degrees on here is going to be about 12 degrees. That's the time for a referral. Water. So, idiopathic scoliosis, so the Greek word, one's own pathosufferate, a disease of its own kind. Because I had to look idiopathic up, because I thought it meant we're idiots, so we don't understand it. That wasn't true. Now, when we look at the spine, a normal spine, which from back and front, it should be straight. From the side, there should be a normal lordotic curve, thoracic kyphotic, lower lordotic. The curves of the spine give the spine strength and flexibility. Kapanji and Govacheski, Kapanji physiology joints, volume 3, and Sergey-Govacheski spinal engines, the number of curves squared plus 1 equals resistance. Dave Harshfield, the radiologist, was here last time, basically says, if we look at this, what we're seeing is, from the center mass of the atlas is 1 curve, cervical lordosis is 2, kyphosis is 3, lordosis 4, sacrum, there's 5 curves. 5 times 5 is 25, plus 1 is 26. So the curves in the spine make it 26 times stronger than it was a curve. When the body loses the good curve, it's going to put in bad curves, and there's a scoliosis. So scoliosis, one thing, is abnormal biomechanics. And this fascinates me. I like anything that's abnormal. And the idea that there's something abnormal with spinal biomechanics gets my juices flowing to find out why. Why is this working differently? As a matter of fact, in a scoliosis, if I flex to the left side, the spondylosis should rotate to the right side. All right? But in scoliosis, they rotate into the concavity. So why does that happen? That's against normal spinal biomechanics, because rotation and lateral flexion are a coupled motion. But if I look at this here, the way the spinal cord goes through the spinal canal, as the spondylosis rotate inside abnormally, that means the spinal cord is going through the valley instead of over the hill. If they rotated normally in scoliosis, it would be like taking that spinal cord and wrapping it around. It's like going over the hill instead of through the valley. So the innate body accommodates this by rotating into that side of concavity. But that's because it's lost the good curve. So the first thing we have to do with scoliosis patients, if we want to fix the bad curves, we have to introduce the good curves in there. Now, the other thing we want to look at is the neurological component regarding scoliosis. I love the upper cervical guys, Luca, Grasby, orthospinalogy. They measured the upper angle, lower angle. I cut it on spinal mechanics for 25 years. I like to be able to measure this, even on that base posterior x-ray as well. The problem is, when we look at this here, your standard technique x-ray analysis, I've got 6 degrees here, 2 degrees here, here's the atlas, okay? Here I've got 6 degrees, so 8 plus 6 is 14 degrees. That's total upper cervical subluxation. When I started looking at this lateral cervical x-ray, I'm going, you know, subluxations are 3-dimensional, right? We should be able to look at it here. So here's the skull baseline, here's the atlas plane line, here's the C2 vertebral body place line. The skull baseline and atlas plane line should be parallel limitation. And one of the first DMXs you showed there was a severe inferior atlas on there. It wasn't even moving. So I've been able to actually sit down and measure that. When I look at this, the skull baseline is off by 10 degrees, atlas plane line is off by 23 degrees. Now this is fascinating. C2 vertebral baseline should be at a minus 10 degrees, that's normal. Now here's the center mass of the skull, right at the sella turcica. So the weight of the skull is pushing down here, pushing this lower neck into a kyphosis. If I come as using the spinous process of lever arm, as I push this down here, change that, I can restore the cervical lordosis just by adjusting the axis. So measuring there, but when I look here now, so we've got an upper angle 6 degrees, lower angle 2, 6 degrees of rotation, that's 14 degrees. When I look at the occiput, that's off by 25 degrees, the axis is off by 2, and the axis is off by 32 degrees. There's 74 degrees of total subluxation of the upper cervical spine when we incorporate this lateral cervical X-ray. I could change this to 0 and 0 and 0, but if I hadn't changed this, I haven't corrected it. As a matter of fact, 74, 64, there's still 62 degrees of subluxation. So being able to understand this three-dimensionally has really opened up my eyes to being a chiropractor, what we should actually be doing. Now, the other thing when we start to look at this, in the upper, when I went to Palmer, this is when BJ was, all his influence was still around, and at that time they were still teaching that the brainstem medulla oblongata comes down the first and second vertebra. Well, I did some research on that and found out that's not true. I think Palmer's still teaching that because when I hang on to the legacy. Right here at the area of the atlas, this is a cross section here, and right here we've got the anterior cortical spinal tract, we've got the lateral dorsal spinal cerebellar tract, and the ventral spinal cerebellar tracts. They have an effect upon the control of the postural muscles in the body. So this is why with the upper cervical subluxation we see that neurological short wave. Now I got Dave Harshfield that sent me this. We talked about the rectum scapularis posterior minor muscle that attaches to the dura. So this is an MRI of actual indentation on the dura indentation on the spinal cord at the occiput atlas area. Now, went into extension to do it. Now what I did here is I took that same thing. Here's my atlas line. Here's my C2 vertebral body baseline. If these two are compressing together, see how it's going to push that dura forward? The one thing with scoliosis patients, instead of an extension of the atlas, I'll frequently see a flexion. So I think when that happens, it'll actually push the dura more anterior onto the spinocerebellar tracts. This is interesting. I think some of you saw this. Decreased vertebral artery hemodynamics in patients with loss of cervical lordosis. This just came out in February of this year. Talking about again how important it is to have the normal curves, the good curves as far as the spine goes. So we look at the vertebral artery, how it goes to the finger transverse area, and how it connects here. Now, as it becomes straighter, it takes the vertebral artery and stretches it like a water hose so it becomes thinner. Patients with loss of cervical curve have shown that less blood flow to the vertebral arteries in this study. Often used down for ultrasound with blind radiologist read it. Abnormalities of natural curvatures, cervical lordosis, associated with pain, disability, poor health. Result of the study case loss of cervical lordosis associated with decreased vertebral artery values. That's when we get the blood supply up to the head. So I think a lot of times in our practices we have to look more at spinal correction rather than spinal symptomatic care. How can we actually change the spine? So I've been doing a lot of different things over the years to restore the cervical normal lordosis, and finally came up with probably the latest thing, which is a hood weight and an anterior chest weight. What I need is a force and a counter force. So the chest weight goes down the front like this, and the hood weight then goes on the back like this. Okay? So now I've got a force here going frontwards and a force here going backwards. So the question is, does it work? Well, let's DMX it and find out. This is where the DMX is fascinating. As a matter of fact, we did it with her. Lordotic kyphotic curve. Quickly see how about that curve is. But I've got to figure out how much weight. I can use 3 pounds, 5 pounds, 8 pounds, and 10 pounds. So a pretty straight little kyphosis down here. 5, 10. Look how about that curve back in. That's me taking a picture of it.
Dennis doesn't work for like because a lot of the necks we'll all see they have a lot of arthritis, like not younger people that are older.
Yeah, I'm seeing. I actually have one guy that was 82 years old. We got the curve back. It's going to take a long, and we have to loosen that spine up first. Okay. There's a mechanical drop piece that I invest. I've got a supervisory traction to give specific spinal asymmetric exercises. We do a cervical lordotic traction with these patients, not a military kyphotic traction. The adjustments alone are very important as well. If not correct.
Which weight can you actually use? Do you put them in motion with the, do they fall off?
No, the weights stay on. Yeah, we do it in motion too. Here's another one. This is interesting. Watch this one. So very military neck, forward head posture. So with the head weight and your chest weight, not too bad. And then I can change the weight, so I did it again. Put more weight down here, and that weight was too much for her. She reacted negatively. So then I put a foot weight on top, and watch this. Her entire neck buckled into a lordotic S-curve and increased the forward head posture. So I had too much weight on there. But this is what's so cool about having that DMX. I can check it, fix it, check it, fix it. 90% of the stuff I do wrong the first time. I'm serious. I go, oh, I just made that scoliosis much worse. I think I'll try it the opposite way. Oh, that got better.
So as they progress, do you add more weight? Is that?
Yeah, we can add more weight. And I'll do a DMX, maybe we come back in 3 months and change it. This is the boy with the severe lower back pain. He's been past, this is 2 months ago, and mom said he's still up on the balance wall. Look at that on the curve. So put the hip weight to your chest weight. See what I mean? Now, it takes 90 days to develop muscle physiology. He's going to be doing this for the next 3 months. I can't control those lines, okay? But at least this allows me to see, do I have the right tool to make this thing function? Imagine not having the DMX, put this on, take an x-ray, go develop an x-ray, come back, take an x-ray. Anyway.
You say they wear it for 90 straight days.
Yeah, they'll wear it for like about 10 to 15 minutes for 90 days, once a day.
That's it.
So here, we give them the head weight, and you can see how it's still buckled here. Didn't work. I should just give up and go home. Good weight, chest weight. Now, better, I'd like to see a little more lordosis in there. So then we went just a little bit more weight. See how nice he brought the curve back.
You put more head weight on that one, right?
Yeah. One more.
Dennis, are they getting any other treatment? Any other
Yeah, they're getting all the chiropractic treatment as well.
chiropractic?
Yeah. Look how nice that came back in.
How about Prolo under that
I
position?
mean, I've been in practice for 42 years, okay, so it's like I get frustrated, so I have to find something different.
Dennis, you had a question back here.
We got a question back here?
Yep.
Okay, Dennis, how about Prolo other in that position?
How about what?
Prolo therapy.
We're going to touch on that in just a minute, okay? It's an interesting
a winner.
possibility. Yeah.
Cell phones with kids, they're constantly
Yeah, very, very
distancing.
bad. So what we do with the kids, we give them these. No, just up straight ahead. Now hold your hands out here. They're angle glasses. There's a mirror in there at a 45-degree angle. So they can lie down on the spinal molding, put these glasses on, read to the computer, play their games, pass those around.
Cool.
Yeah, because I was seeing, kids did really good in the summertime, then when they came back after school started, this all of a sudden we started to see reverse curve in the neck. So we teach them how to keep that curve in there. We do spinal molding and a cervical roll. Comparison of conventional post-spine radiographs. This is with DMX. We're really finding out that it's 92% less radiation. A 14 by 17 scoliosis X-ray with central ray center to T8 is 15 times less radiation than a medical full spine X-ray. So why not take them on 14 by 17? This came up in 2006. National Research did a thing on ionizing reservation. One of the problems was the Bayer 5 modeling is that relies very heavily post-mortem for dated survivors. The notion that X-ray is bad for you comes from the 1940s, and it's never been proven. Another problem that they found out, research at Vanderbilt reported that DNA are capable of efficiently repairing radiation-induced DNA damage. So the body can heal itself from that. So I was looking at a couple other ones. Here, balance accounts and risk. This just came out in February of this year. The widespread belief that radiation from X-rays, CAT scans, DMAX, and medical should cause cancer is based on unproven decades-old theoretical model, according to study published in the American Journal of Clinical Oncology. Risk estimates based on only theoretical, yet they've been conclusively demonstrated by empirical evidence. So they've taken old junk science and brought it to this age, and guess what? It doesn't work. It doesn't apply. The human body is involved in building paradigms from low-dose radiation. Studies of atomic bomb survivors and other epidemiology studies of human population have conclusively demonstrated that low-dose radiation exposure can cause cancer. As a matter of fact, what they've actually done is created like a radiologic phobia. Another article that just came out, mismeasure of radiation. Low-dose radiation-induced carcinogenesis has never been demonstrated by empirical evidence. The media picks this issue regularly using "if we scare, we care" principle to bolster readership. After Chernobyl, voluntary abortions and suicides increased due to radiophobia, despite there being no data to support LDI-induced genetic effects, no demonstrated increase in solid cancers or leukemia, no proof of other non-malignant disorders. More people died from suicide and abortions than they did from the radiation poisoning. Poison is in everything, and nothing is without poison. The dosage makes it either poison or remedy. This is Paracelsus in the 16th century. So yeah, there's a lot of fear in regards to that. I think it's a bunch of junk. This I found interesting. This just came out last month. Changing lives of patients with cervical spine imaging in emergency room departments, right? And what they found here is that basically X-rays have reduced, but CAT scans have increased by 8,864%. So CAT scans are way up. And where do you get the most radiation from? CAT scans. MRIs are actually down, but that's the new thing now, CAT scans. On our website, Josh and my son actually wrote a whole thing regarding the guidelines, clearing my protocols, DMX, we've got all kinds of information on that in regard to radiation. Not that I'm so smart, it's just that I stay with problems longer. Einstein said that, and I have a DMX. So here's the scoliosis traction chair. I had mentioned this a while back. It vibrates, it tractions, and it derotates simultaneously. You only have to do this for 30 minutes twice a day compared to wearing a brace for 23 hours a day. Anybody ever wear a scoliosis brace? I had a boy came in who was a little bit smaller than I am. I put it on and wore it for an hour. There's no way that I can wear it. Compliance is maybe 30% with bracing. But I've got to make sure that everything is perfect in regard to these pads, where I want all the right forces going in as far as the body goes. So I DMX it. Here's the thoracic strap. Here's the top strap. So we've got the picture here. This is the thoracic cob angle. Coming down to the lumbar cob angle. You're using DMX for just personal injury. You're wasting your time. It's so much more fun than this stuff. There's a gas. So then I can figure out the placement. And then from that, I can actually take an x-ray. Now, if it's 60 degrees, we get them down to 17 degrees and 47, which is 47 degrees down to 30 degrees in the scoliosis chair. And well, this is really good, but this kind of sucks. So with the DMX, I changed the placement, did it again, took them 60 to 17 and 47 down to 12 degrees. It was only because I could DMX and see it again that made it that effective. All right, ALR time. ALR instability is rare, isn't it? I mean, it's not, it doesn't happen very commonly. I would say anecdotal clinical research, I found ALR instability present in about 5% of the general population, probably 30% of whiplash car accidents, especially those where the T-bone effect takes place and the head gets rotated and extended at the same time. I find ALR instability in 85% of chiropractors and their spouses. 85%. Remember chiropractic college? Let's get a 12-pack of beer and adjust each other. Nobody else ever did that besides me. So Wednesday before I left, I told my office staff, I want to find out what the correlation is between my scoliosis patients and ALR instability. And I can do that as DMX. So I said, I want you to go back and go through. Here's the age of the patient, 64, 13, left alar, right alar. I think there's a definite connection between birth trauma, alar instability, and scoliosis. When babies are first born, what happens is the head comes up, and if the doctor will wait, they will innately turn so the easy shoulder comes up. But if the doctor's in a hurry, he's going to pull one leg, pull the other leg, there goes your alar. Now babies can't hold their head up, so it drops off to the side. When they do start to hold their head and come to gravity, see how that shoulder comes up? So I think my personal opinion is that there's a very strong correlation between birth trauma and scoliosis patients, but especially between alar. So far they've only got through 366 files, so they've got another 1,000 to go through. But 352 out of 366 had alar instability. That's 96.17% of scoliosis patients have alar instability. That's
What's your parameters for?
basically over 3 millimeters.
Over 3
Yeah,
combined or on one side?
one side.
Okay.
Yeah.
Pretty significant.
Pretty significant.
Wow.
Went from 3 years old to 82 years old, 132 had known birth trauma. And that's when it was a C-section, parents actually knew. I think it was a lot higher than that. 54% had right alar instability, 45% had left. And I think it depends if you got a right-handed gynecologist, obstetrician, or left-handed. Okay? But I know there's a correlation between that, so we're starting to put together some stats with the DMX verifying that. So we look at injuries of the skull base. Dave Hirschfield was not kind enough to send this to me. Alar tears. Okay, here's the alar ligament. Here's the alar test. See how the head goes out to the side? Comes back to the center. This is the coach's eye. So I decided to DMX here in base posterior film as well. This was about 5 years ago.
All the way up, straight ahead. All the way up,
See how the head goes out to the
straight ahead. All the way up,
left side.
straight ahead. All the way up, straight ahead.
So I can actually see the lateral mass dented and how that whole thing is dropping over. So how do we get alar instability? A lot of things during our daily lives will actually cause it. Like the Brad Pitt. Instant alar instability. Chris Centeno, you guys probably know him, but he did a webinar a while back, and I found it interesting, like 2 weeks ago, and I contacted him. Because he's talking about doing alar injections, the type of prolotherapy, instead of doing this type of surgery, like Dr. Frank would never do.
No, I don't do that.
But what he's talking about doing is coming in through the articular gaps here, coming in from the front, and doing injections that way. Now, I have an alar fetish, okay? I'm fascinated with anything about alar. So any information that I can see, I think is interesting. Being able to talk with the medical doctors, the surgeons, Dr. Ross Matilda, I think is fascinating. So this is the transverse ligament coming in from the front. He actually has to knock the patient out, okay, with a special appliance to keep the mouth open, keep the tongue depressed. Matter of fact, Dr. Joe, we even talked about this last year, about coming. Last year we'd actually talked about coming in from the front. We had mentioned that. Now, he's only done 12 of these so far, so it's in a very infantile stage, but I think it's interesting. Being able to visualize and being able to see what's going on there. Injecting the alar. Don't try this at home. But I had talked to him before. One of my questions was in regard to alar and scoliosis, and he said because of uneven load, scoliosis patients would have more alar instability than other patients. So I got him to agree to that. I thought that was pretty cool. So we start looking at the nasum X-ray. Here's the lateral mass density interval on the right side. Here it is on the left side. So what does that tell us? Absolutely nothing. Okay? Without seeing this in motion, you don't know what's going on. Because that would think, well, there's right alar instability here, and now DMX on the left side is much worse. Simply because the body has a protective mechanism. If I come and do this, see how his head goes off to the right side? It's going to protect it. So a lot of times in acute injuries, the lateral mass dens interval space is going to be less on the side of the alar instability. But you're not going to know that unless you do the ADP, lateral flexion, open mouth. So, I paid $250 for this book, okay, to get one page out of that book. This is atlas normal Röntgen variance that may simulate disease. So what we're looking at here is the normal dense lateral mass. We can see the space, all right, produced by rotation of the same patient with head rotation. So now when they rotate, the lateral mass density changes, but notice that the lateral mass is equal on both sides. We're not seeing an overlapping here. Remember when Dr. Ross showed those pictures, actually John, you had shown them before, so what's really going on there?
Okay, left here, left shoulder.
There's some slippage here,
Back up to the
about
center.
4 millimeters,
Right reader, right
right
shoulder.
side, about 5 millimeters here.
Down there.
There's
Back
that
up to the
slippage
center.
right there.
Close your mouth. Turn your head to the left.
Now you're going to have hypermobility to the side of alar instability. So if I've got right alar, it's because alar is a check ligament. It holds it in
Wide,
position.
turn your head towards me.
Now watch. See how I've got the, instead of doing this and turning, I've got it here and turning.
Again. Turn your head towards me.
See what we're seeing here? So I think we need to do both ways, especially this one as well.
Center, good.
And here's the reason why. So. And here you are. And you might want to use this one in court.
All right.
First of all, I'm really happy that Walmart has self-checkout. So, what am I? I'm sorry. Hang on.
C1, C2.
Yeah, so here's the alar ligament, and here's the atlas, okay? So as the ligament goes off, becomes lax on this side, you see how the atlas is going to shift off there? The alar doesn't attach to the atlas at all, does it? So it's the instability that allows it to slide away, just like when we park a boat at the dock, and the line, the rope on one side break, it's going to slip away. Now, the thing is, when we start looking at alar, when you adjust that, you've always got to adjust it on the side of alar instability, so from here to here. If I come on this side, I'm just going to jam the lateral mass into the dens, and that's not going to feel very good. You don't think I dream about this stuff?
That's what I was thinking.
I come here. Question? Yeah, I did this before.
Are you selling your chairs?
What?
Are you selling those chairs?
Yeah. Yeah. So, watch this when I go to the right side. See that slippage there? See the alar instability? But not on the left side. So it's only on the right side, and this is me. Now I was really fortunate. 6 years ago, it was like 80 degrees in March in Minnesota, which is unusual. So I decided to carry my deck chairs down to in front of the house, and the ground was still frozen. So I slipped and fell down really hard, and actually gave myself right alar instability, which is really cool, because now I got a norm and an abnormal. So now I can compare the left side and the right side to see how it functions. So, and I can actually adjust this. This is with the arthro stand. So I'm adjusting myself and DMXing this at the same time. Look at the slippage here. Oh, I've got like 10 different studies at one time to show all that. Even with the cell phone, what happens in the alar. Here,
With that adjustment.
it's a little bit,
You can't see the tool, but it's there.
this is the side of alar. And I have to check it.
It has to be there. You have to have the video.
Is that what it is?
Yeah.
It hurt a little bit.
That hurt.
There, it puts it right back in there.
Wow.
We need a longer cord for it so I can DMX and do it myself. Like that. So here's the alar test going out to that right side. I've got right alar. So I did a base posterior. Lateral mass goes in large on that side. It goes up. Here's the right side here. So it's filling out to that right side. So a lot more with this to play with. And I don't turn the machine on. So, this is an exercise that we do to help stabilize alar instability. It actually works the rectus capitis close to your major muscle that attaches from C2 up to the occiput, and its purpose is to extend and rotate the head. Well, if I work it isometrically, I can actually get that muscle to kick in to stabilize this area. So it's a conservative treatment. It doesn't work like an ossificant surgery, but it seems to work really well when I incorporate the rectus capitis close to your major muscle. I've DMX'd all these exercises. We do all kinds of scoliosis exercises for patients, and I went through and DMX'd them, and 30% of them I threw out because they didn't work like I thought they should, and DMX proved it. So it's just a cervical dorsal isometric alar exercise, not on the side of alar instability, about 5 degrees of the left lateral head towards the side opposite of alar instability, and do it isometrically, not isotonically. Postural spinal muscles only respond to isometric, not isotonic exercises, so it's a push and a hold. But it works. So then I wanted to see if I have a protractor and alar, how far do I have to chill before I start to see alar instability? So this is my protractor here, and I got a metal thing going up here. Okay. So as I come down, a little bit there, and I'm watching the degrees here, and right at 20 degrees, I start to see it slip. So I can tilt 10 to 20 degrees without any problem. Over here, so this is farther. Now we're getting a little more slippage here. What do you guys do in your spare time?
Is insurance reimbursing you for this?
I pay myself cash. So yeah, and this is like greatbigstuff.com. You get a really big protractor, comes in real handy. But then I also wanted to check in regard to rotation, as far as what angle. So here it's not bad at all. Then I put the protractor underneath my chin. And again, I find right about 20 degrees, that seems to actually affect it. One slippage right there. Left side is fine. Here's the rotation one. So this is the left side, not too much, okay? Now watch the right side, that's the side of the alar instability. Look at that overhang here.
Yeah, amen.
Isn't it so cool? I only have alar on one side?
Yeah.
Yeah.
Yeah. Definitely.
Okay, this is Sarah. Same thing with her. She spent 4 months in a mental hospital. I think it's related to the alar. Dr. Joe, she's talking to me about this. She got a people in the picture. She's got about 8 millimeters on the left side and about 2 on the right side. What I did with her before we started, I just took her head and moved it back and forth forcefully through passive ranges of motion. Then I did it. Not too bad here. A lot of times we'll do this forward head posture, you gotta bring the head back and get it to line up with you.
Back up to the center. Right here to right shoulder. Chin off of the line. Chin down a little bit. Chin
Not
down
too
a
bad
little more.
here.
Good. Back up to the center. Okay, again, left your left shoulder as far as
Left side.
Okay, turn your nose to the right there.
There's the center right there.
Hold it right there. Okay, back up to the center.
No headaches, no neck pain, occasional right upper back pain, that's it.
Chin down just a little bit. Back up to the center. Okay, left.
Close up view, just had to step forward.
Chin down a little bit. Follow wide. Chin down a little bit.
So actually, Therese came in actually repositioned as we can see it. There we
Now
go.
back up to the center. Now go down to the right side. Chin up just a little bit right there. That's good. Back up to the center. That's perfect.
Now she used to have really bad in the left and stabilize it, then she had another fall on
Turn
the
to the left
other
as far as
side.
it can go.
Now, hypermobile to the left side.
Now go to the right side. Okay,
is another guy, he's a Ferrari salesman in Spain, he came to see me. Alar's not bad here at all,
All the way over,
and not bad here.
shoot down this
But he doesn't have a lot of flexibility, so I'm thinking, well, he doesn't have any alar instability at all.
Head towards me.
But when he turns his head,
Keep going, keep going, keep
look at
going.
the slippage here. Now, I would have missed that
Down the
if
straight
I had done a
path.
rotation.
Again, to the left again.
So I think a lot of these people kind of guard it, they don't want to go so far for rotation. And when you rotate, you close out the spinal canal by 50%.
All the way.
It decreases in size.
Good.
That's what really was the stress.
Once more.
So he's got bilateral alar, but it doesn't show up in the lateral flexion.
And
You're saying, just explain that again, the spinal canal.
This is the spinal canal, wherever the spinal cord is.
Okay.
Okay, if I rotate, it'll actually close up about 50%. The spinal cord occupies 30% of that space.
Can you explain the anatomy as to how we miss it on lateral, if it shows up with rotation?
I'm working on that.
Okay.
Not yet, but I think we all said. So the next thing I wanted to do is find out when I was sleeping, what side is better for me to lie on in regard to alar. So I decided to be an expert. Okay, now here I'm lying on the right side, and this species on that right side.
Not one side,
And guess what? When I lie on the left side, there's no slippage. So for 3 months after I did this to myself on purpose, I slept on the left side and I was fine, but I could not sleep on the right side. So if they have alar instability, have them lie on the opposite side, they're going to sleep better.
Well, you need to ask the witness, is that true?
What?
The witness, the missus, is it true?
He always sleeps pretty well. I'm no judge.
I know I'm in my own little world, but they know me here.
Great.
All right. So, I taught spinal biomechanics and pedabone for like 25, 30 years. I looked at the upper angle, the lower angle, the C2 spines. I was really good at manipulating the neck. I was one of the best adjusters I ever followed in the instrument adjustment. I could get chiropractors' wives' necks to move when they could never do it. So the idea was something like, it was okay to crack patients' necks. And this is actually from the World Health Organization. This is covered successful spinal manipulation or mobilization involves application of force to the areas of spine that are stiff or hypomobile while avoiding areas of hypermobility and instability. See where this fits in with you, Dr. Ross? So I'm finding that if a patient has spinal instability, we should be cracking and popping these necks all over the place. As a matter of fact, Cassidy, this came out in January 2013. They looked at the cavitation when they did the diversified adjustment. So they did all kinds of sensors and peak potentials and whatnot. And bilateral popping sounds were detected 91.9% of the 37 manipulations. So instead of being specific, this is a generalized mobilization procedure. So, remember the toggle? I had 7 quarters of this in Palmer. That's DMX. Now, if you're adjusting on the side opposite the alar, I mean, we did this. We would toggle patients and walk away and wonder what that did. In the last 9.5 years since I got the DMX machine, I haven't done any type of cervical manipulation of patients or adjusting cervical manual. Okay, I only do instrument adjustment. And since that time, first of all, I get along a lot better with the medical doctors who are afraid to be cracking off people's necks. I get much better results. I mean, the pre and the post sectors are fantastic. They hold their adjustments longer. I went 3.5 years once without having my neck adjusted because I didn't need it. And we think we're supposed to get adjusted every single day. You create hypermobile segments, people. You can't do that. Remember I said 85% of chiropractors and their spouses have alar instability? Guess what that's from? Cracking and cracking. Now, it was really hard for me not to do that. Years ago when I was at Palmer, I asked a friend of mine, because I had an adjusting instrument. I said, well, chiropractic is my hands only. I have to use my hands. He goes, Dennis, you have to decide what's best for your ego or what's best for your patient. I mean, I got magic hands, that's right. Almost done. Came up with a new exercise. Now, in lateral flexion, all right, what we're looking at here is the quadratus lumborum muscle is the lateral flexor of the body, right? So when I laterally flex to the right, this muscle starts to tighten up. It's the only lateral flexor as far as the trunk goes. But guess what? This is a scoliosis patient. And what you're going to see is this QL on this muscle is really tight. This area here is hyperactive as far as the muscles go. This is what one patient calls the dead zone. There's actually a hollow in that part of the back. But you see where we start talking about abnormal biomechanics, the QL should be activated here. It should be kicking off and firing like crazy, but it's not. It's doing it on the opposite side. So my question is why? Why is that happening? When I start to look at it, I've got the thoracic spine hanging out over here, and the QL muscle here has to tighten up, otherwise that thoracic spine is going to keep getting worse. So the body has to compensate for that. So this, I mean, this thing is like rock hard.
Yeah.
And this one you can put your fist through. So I'm like, well, that makes sense. How do we activate the QL muscle on the right side? I've tried different exercises. QL attaches to the rib at T12, transverse process here, and the ilia here. And when I lateral flex to the right side, this is going to decrease my thoracic, but it's going to actually increase the muscle activity here on the right side, because this is a lateral flexion. So yeah, this comes down here, but this is going to kick in, but it's going to make this top angle much worse. But here's that QL muscle again, trying to activate that. So I actually came up with a scoliosis bar. I mean, this was like 2 months ago. So they hold the bar, and now by bending to the right side, it activates all the thoracic muscles here, and so the thoracic muscles, kicks in the QL down here on the right side. So I actually had to DMX this, okay? And the whole presentation. You can see how it's going to work. I'll just speed this up. So here she's bending like this, and this is making this curve much, much worse, okay? But it's activating this QL muscle. And when she stands up, that QL kicks in and pulls the lumbar cob ankle back out, also improving this one at the same time. See why I couldn't practice? I didn't have my DMX. So this is what we're looking at here, trying to kick this muscle in. So we did a myovision, a surface EMG. So here's a normal patient. Here's a typical scoliosis patient. See how these right thoracic muscles are firing down here? When we had them bend to the right side with 10 pounds, look how these muscles kicked in. This side stopped firing, this side started firing. So comparison-wise. So it actually went from 928 units of muscle activity to 1,817 units of muscle activity. I'm going, Eureka, this is it. As a matter of fact, this is Shyam. Shyam just finished with us last week. He's from India. 56.68, we got him down to 37.58. He came back 4 months later, 43.55. So holding pretty good. But then we started the treatment and introduced this new exercise. He's down to 32 and 43 from 56 and 68. And I'm convinced it's adding this new scoliosis bar that I was able to DMX. It's changing everything.
How often do they have to do that?
They're gonna do that at home until they fatigue. Just until they get tired.
Every day?
Every day, yeah. Sometimes twice a day. So let's say they had a real busy day and it's late at night, then I'll be able to do it for 3 minutes. They had a relaxing Saturday, they might be able to do it for 10 minutes, but I just want to take them to fatigue and then stop. Okay, so I went through this a few years ago. God keeps giving me challenges to learn from so I can teach other people. So about 8 years ago, I flipped a snowmobile on purpose. Now, a snowmobile for you guys from Florida is like a jet ski that goes on the snow, okay? So I flipped this snowmobile and I did a grade 4 EC shoulder separation. I mean, that's going to hurt really bad. So I
Was
went
that
in.
intentional?
I told Brenda it was.
He meant that.
Yeah,
I meant that.
And they said, oh yeah, we're going to schedule for surgery. I said, well, wait a second. Isn't there some way I can fix this? Isn't there a brace or exercise? He said, no. Because what you have to do is you have to pull the clavicle down and bring the shoulder up at the same time. There's no bracing, no exercise to do that. So I went over to the office and got out the DMX. Here's the clavicle. And what I did is I just put a band around here. See how I pulled it down into position? Now, I did that 8 years ago. I do this exercise every single day, okay? And I don't have any, it's completely functional, okay? So, EC bands. I know you will. We also have the shoulder problem. One left. So it's just a matter of putting that band down, going through little circles and hold everything back into place. Roger Turner, as a chiropractor, does cranial work. He did the same thing to his shoulder, and he had a pin put in, and he wakes up 4 or 5 times every single night. So that works. Vie for Health is the company. There's brochures here. They sell a lot of different equipment.
The scoliosis traction chairs.
As a matter of fact, the vibrating platform that I invented is not for exercising, it's for neuromuscular re-education. It has to be exactly at 30 hertz and 0.3 Gs, okay? I buy vibration platforms from another company and I test them, and a lot of them are really bad. They're even above OSHA standards as far as vibration goes.
So if I use that vibe plate,
The ViBrate
yeah, usually what frequency?
has to be at 30 hertz, it has to be 0.3 Gs. Anything more than 0.3 Gs is going to cause damage to the body. Scoliometer, air disc cushion, you have the kids balance on this for the neuromuscular education, types of traction. This is a cervical vibrating traction, it's electronic, it actually vibrates at 4.5 hertz, which has been shown to relax the ligaments and muscles for getting the cervical curve back in. Traction adjuster, this is mechanical drop piece, arthur skin, Becker table, all this stuff that we use. And we just started a brand new website. Because Clear is a non-profit organization, we want our website to really reflect that. That's been working really well. I got a patient coming Monday after I get back from Germany. We get patients from all over. I used to think BJ's Trauma Clinic was really cool because people like come all over to go see him. Cool. Yeah, Malta, England, Italy, a lot from the United States. 50% of our scoliosis patients are probably not locally come from some other part of the United States or the world. Oh, and we've got us clear, and we're looking for more clear scoliosis doctors. We have a clinic in Panama, we're opening one in South Africa. In a month, we're opening up one in Madrid, Spain. We've got one in Tokyo, 2 in Singapore, 1 in Malaysia, the beginning one in Bulgaria. Scoliosis epidemic. And it is a progressive disease. As chiropractors, we should be the spinal experts that know how to help scoliosis, and we know nothing about